training at the Ghana College of Nursing and Midwifery Fellowship in Pediatric Hemo-Oncology. Ladies and gentlemen, our keynote speaker for today is no other person but Mr. Courage Arnold Yao Fully Kwame Kuma. This person, I think the first time I met him was on my clinic house at the Hohoe Municipal Hospital then, when he was the service personnel. I know he has a lot for us, and thank God we have him on today. So, Courage, if you can hear me, the floor is yours. You are welcome.
Okay, thank you very much, Jonathan. Can I be heard?
Yes, please. Very loud.
Okay. Thank you very much, Jonathan, and good afternoon to you all. Good afternoon to all senior colleagues and mentors online. I wish to indicate that it's both an honor and a profound responsibility to be the keynote speaker today. Generally, the team across is a national call to action, improving jaundice care in every newborn, everywhere. And our rallying cry this year is simple, yet very life-saving. Spot it early, treat it right. But before I get in, generally, the data indicates that mild jaundice occurs in a lot of preterms, at least about 60% of 10 babies and 80% of preterms would have some mild jaundice. And the neonatal jaundice is estimated to affect approximately 9 to 244 per 100,000 live births globally. Population-based meta-analysis found overall case of severe neonatal jaundice incidence to be 9.9 per 10,000 live births. But there are striking regional variations, and it would surprise you to know that the case of Africa, it's 607.8 per 10,000 live births. Not to bore you so much, I want to focus on the reality in our region so that I can ground the discussion on our teaching hospital and some district hospital data over the past 3 years, which reveals some progress and persistent gaps. Data available in DIMS has it clearly that for the case of the district hospitals, I've tried getting data from all the way from Peki to Ketu North, all the way to some of the private facilities in the region, including King's Hand, the National Mission Hospital and all those ones, Ghana Mission Hospital and all those ones from DIMS. Now, on one hand, we see it has reduced its neonatal jaundice rates from 8.7% in 2023 to 5.6 in 2025, which could be a testament to focused clinical protocols and staff dedication and the desire to screen. It's interesting to note that a lot of our private hospitals, particularly Central Hospital in Aflawu, Georgia, Ghana Mission Hospitals, generally report 0 jaundice rates. And as somebody who works in the space, that would virtually sound impossible because with good screening, you would pick some of these things. And it also means that possibly testing is also a challenge in those hospitals. And if you get to testing capacity, you would also note that these hospitals are not testing much. And so that is not a good thing for us. However, across all the district hospitals, Peki government hospital seems to continuously report an increasing rise of 19%, uh, which is nearly 1 in 5 newborns delivered. And this is not just the statistics. These are babies who need our urgent attention. As I indicated earlier, across several facilities, bilirubin testing capacity remains a challenge or very inconsistent. And a lot of hospitals are recording zero capacity to test. But some facilities like Margaret Marquardt Hospital and the Keta Municipal Hospital have consistently, with data available in DIMS, recorded very high capacity to test. It's sad that as much as 11 facilities, mostly private facilities, and so it calls for how we could integrate them properly and build their capacity in testing, because 11 facilities reported zero bilirubin tests in the whole of 2025. Keta Hospital reported about 1,922 tests, correlating with a detection rate of 5.5%. Peki Hospital, 1,418, which with the highest detection rate of 19.8%, which indicate both a very strong surveillance and a serious underlying burden. And so we have a call to action. And that is why we have a rallying call this year, Spot It Early. When we say spot it early, it means training every birth attendant, every community health nurse, and parent to recognize a hint of jaundice within the first 72 hours of life, particularly within the first 48 hours. Spotting it early also means that we need to ensure that every facility, no matter how remote they are, has access to reliable bilirubin screening tools. And some of these tools are just physical assessments. That does not need a high cost burden. And it's important that we also integrate jaundice checks into every postnatal visit. It must be routine that every immunization appointment or every home visit a community health nurse or a public health nurse does, or a midwife does, we should be interested in assessing the babies for jaundice. And we are calling that we treat it right. And that also means that we need to standardize phototherapy protocols across all facilities. What we do in facility A must commensurate with what we do in facility B, so that it also helps with teaching and learning. It's also important that we strengthen referral pathways. And when it comes to the subject matter of referrals, I know how deep and how bad it can be, especially for a place like the teaching hospital, because I work in the regional hospital where you are just there and the people come. And it's important that we empower families with clear and culturally appropriate education on follow-up care. It's also important that we bring the churches, the traditional authorities on board, because, see, leaving them isolated leaves a lot of myths that still guide the way parents and families respond to jaundice today. the data in our region generally uh, is something that we must all be concerned with. At the Whole Teaching Hospital, we have consistently also had some increases in admissions regarding neonatal jaundice from 95 to a peak of 75, 275 admissions, which represents about 189% increase over 3 years. And the most dramatic surge was between 2022 and 2023. However, in 2025, there was about 18% decline to about 225 admissions, which suggests a potential improvement in early detection, prevention, and outpatient management. So these cases probably did not end up on admission. And so the data we see is not just an issue of data. It reminds us that we still have issues with inequity in access, which leads to inequity in outcomes. When you have a newborn in one district, that's me. It's my hope and appeal to our facility managers on board and departmental managers that we consider auditing our jaundice screening and treatment readiness. Is very, very important. Just like we treat emergency readiness, we need to consider having a jaundice screening and treatment readiness policy guides or standard tools. We also need to prioritize funding for neonatal diagnostics and staff training. Sometimes we underestimate some of the burden of some of these things, and we presume that, oh, because they were trained, they went to school and all these things. But sometimes people have not even been exposed to some of these issues. It's also important that as health workers, we ensure that we are the eyes that spot it early and the hands that treat it right. Let's get our communities involved to know the science. Let's encourage them to ask questions and demand care. And so to conclude, I want to say that every yellow tint we catch early is a brain protected. Every timely treatment is also a future secured. It is my hope that we leave this webinar not just informed, but activated. Let us turn awareness into actions, data into decisions, and let these decisions reflect in the kind of compassion we give in our approach to the care of the newborns to encourage the next person to come back. And because when we spot it early and treat it right, we would not just be managing jaundice, we will be protecting generations to come. And so I thank you all, and together, let's answer this call and ensure that we spot it early and also treat it right. And let's take the presentations that would be coming soon very seriously and learn useful lessons from them. Thank you very much. Hello, thank you very much. So that will be all. Hello, Jonathan, over to you.
Thank you, Brad Courage. There was a technical fault that the host was not allowing me to unmute, but that has been corrected. Thank you so much for the speech, and I'm sure that has gone down and very well with us. So we would have our chairperson being introduced for this session, and the chairperson for this program, she is a medical doctor by profession. She also worked at the whole polyclinic and is no other person but Dr. Ekuban. Dr. Ekuban, if you can hear me, your audience are here and are waiting for you. Thank you. Hello, Dr. Ekuban. Hello. Hi, everyone. Can I be heard?
Yeah, hello. Can you hear me now?
Yes, please. Yes, please. We can hear you now.
You had not unmuted me earlier.
Oh, okay.
So, good evening to you all.
Good evening.
Good evening.
And once again, you are all welcome to this important webinar. I accept to chair this webinar to a successful end with your support. And what I'll say is that globally, we know that neonatal jaundice affects about 60% of term and 80% of preterm infants. And this is in literature. Approximately 1.1 million newborns develop jaundice annually. And the highest rates occur in sub-Saharan Africa and Asia, for which Ghana finds itself among. In Ghana, neonatal jaundice is a critical public health issue, affecting approximately 32% to 66% of newborns, and this is in regional studies from Ghana Health Service website. And it accounts for an estimated 40% of under 5 mortality, and also a leading cause of preventable cerebral palsy in the country. So neonatal jaundice is a major cause of admissions, as we had even heard from the earlier speaker, close to about 8.2% in our admissions in our bigger facilities. And over the past years, pediatricians, pediatric nurses, and other health workers have championed the awareness of neonatal jaundice through advocacy in several ways, which is commendable. However, there are a few gaps to close up on maternal or caregivers' awareness about the causes and appropriate treatments for neonatal jaundice. Because we are still having some traditional practices like the usage of naphthalene balls or camphor, which is in baby's clothes, which is a risk to neonatal jaundice, and other unsafe practices. Hence, there is a need for pediatricians and health workers to update our knowledge on neonatal jaundice through forums like this webinar and continue our advocacies on neonatal jaundice to fill in the knowledge gap and deepen the understanding of caregivers about this menace. Our presenters, I believe, have prepared for us current updates on neonatal jaundice, and I entreat all of you to relax and enjoy their sessions, after which we'll have meaningful discussions and comments. Once again, you are welcome and thank you. Over. Hello.
All right, thank you, Dr. Ekuban, for accepting to chair the webinar for us. So without much ado, we would dive into the presentation following the literature we've heard from the chairman and then the keynote speaker for the program. I'm very sure we are all ready with our pen and papers, putting our questions together. So we would have our first speaker, who is a pediatrician at the Margaret Marquardt Catholic Hospital, Bando, in the Volta region. He supervised clinical care at the general pediatric unit, including outpatient and inpatient care. He was a resident at the Comfort Noche Teaching Hospital in Kumasi. Ladies and gentlemen, help me welcome Dr. Pepra Philip as our first speaker for today. Dr. Pepra, if you can hear me, over to you.
Yes, please. Good evening. Can I be heard?
Yes, please, you can be heard.
All right. Thank you very much, Mr. Jonathan Kwashi. I think it's a big privilege as I begin to load my slides. Thank you very much for inviting me and giving me this responsibility to share some insights on jaundice, neonatal jaundice, especially during this period. Just to confirm, Jonathan, please, can you confirm if you can see my slides and hear me properly? Hello, Jonathan.
Yeah, we can see your slides.
All right. Thank you very much. Thank you. Okay. So today I would be focusing more on complications of neonatal jaundice. Since over the years, I think we've had a lot of talks on neonatal jaundice, and I've been tasked to talk more about the complications and any updates that are available. So this will be my outline. I will do just a brief overview of neonatal jaundice, and I think we've already heard a lot about it. And then I'll go straight to the bilirubin-induced neurologic dysfunctions or disorders that we've heard about. And then we'll talk a bit about their management. So as we all know, jaundice is the yellowish discoloration of skin and sclera in newborns. And it's usually due to the accumulation of unconjugated bilirubin in the skin and subcutaneous tissues. Now, the major problem is that unconjugated bilirubin tends to be neurotoxic, especially when it crosses the blood-brain barrier. And that is where we see most of our serious complications happening. And we'll talk more about it subsequently. Okay, so normally the level of bilirubin in the cord is about 1 to 3 milligram per deciliter, and it rises at a rate of less than 5 milligram per deciliter in 24 hours. So that is why we tend to see it become more visible in the eye and skin on the second and third day. And then we see it peak on the second and fourth days. And then by 5 to 7 days and thereafter, we are supposed to see it drop. And just to draw your attention, I'll be using different values. So if you want to convert from one unit to the other, it's written down there. You multiply milligram per deciliter by 17.1 to get micromole per liter. And this is because some of the labs may alternate or use different units. All right. So I'm sure we've all heard of bind. Now, bind does not necessarily refer to a particular condition, but actually the spectrum of disorders that result from the brain injury from high levels of bilirubin in the blood. So within that, we have acute bilirubin encephalopathy, which refers to the acute signs of bilirubin neurotoxicity in the newborn, particularly within the first week of life. And then when this persists, that is when it can progress to chronic bilirubin encephalopathy, which was previous or still is called kernicterus. Understand? So bind and kernicterus are different, slightly different entities. You can sort of say that kernicterus is under bind. So bind is that broad term And then under that, we can have acute bilirubin encephalopathy and chronic bilirubin encephalopathy or kernicterus. So kernicterus is that extreme form of bind where you are having permanent brain damage, and it manifests in different forms. And we'll talk more about that later. Okay, I think we've heard a lot about this already, but I was trying to look for incidents of bind in our part of this world, and there is not much information, not necessarily on jaundice, but actually bind. It wasn't, there wasn't much to find or much data to tease out. But then I found that when they have levels of total bilirubin around 30 milligram per deciliter or more, the reported rates of acute and chronic bilirubin encephalopathy tend to range from about 10 to 30%. Okay, so just a quick overview of the pathophysiology so that we can understand why we have these complications. So we all know that bilirubin is produced from heme based on the enzymatic processes. So heme comes from RBCs and other heme proteins. We know that heme is broken down to bilirubin, then biliverdin, and biliverdin subsequently is converted to bilirubin. Now, this bilirubin is bound to albumin in the serum and then transported to the liver. So albumin serves as a vehicle to transport bilirubin to the liver. So the levels of bilirubin is not necessarily the real problem. The real problem is the levels of free bilirubin, which means that if there's more bilirubin than albumin to transport to the liver, then you're going to have very high levels of free bilirubin. And that free bilirubin is going to be free to move into the brain to cause brain damage. At the same time, if you have even moderate amount of um, uh, bilirubin, but you don't have enough albumin to carry this bilirubin to the liver, you can also get severe effects from that, just because there's no vehicle to carry that free bilirubin to the liver. Now, as it goes to the liver, what happens is that it's going to be conjugated. Conjugated means that it's going to be water soluble. Water soluble is going to means that it can now be excreted in the bowel and also in urine. Okay, so from the bowel, that it goes into the duodenum, and then in the duodenum is going to be acted on by an enzyme which is called beta glucuronidase. Now, this causes unconjugation of the bilirubin, and that bilirubin, that unconjugated bilirubin, can now be reabsorbed into circulation and carried into the liver or systemic circulation. And this cycle is what is called the enterohepatic circulation, which means that if you have high amounts of beta glucuronidase, you're going to have high amounts of unconjugated bilirubin going back into systemic circulation, which could lead to high levels of jaundice and then increase the risk of complications. Now, as the infant grows, usually some bacteria begin to colonize the gut, and they can now transform the bilirubin into stercobilinogen and urobilinogen, and that is excreted in stool and urine. Okay. Now, since we understand that, now we can understand that some of the causes of neonatal jaundice, which I'll briefly go through. So if there's increased production, we know that it's coming from higher levels of RBC destruction. So we have ABO incompatibility, resource incompatibility, hemolysis from infection, and then bed trauma, cephalhematoma, subgaleal, and others. And then we know G6PD and other hemolytic disorders. And then if you have decreased bilirubin conjugation, it means that most of it is going to be in circulation. So conditions like pregalania, Gilbert syndrome, hypothyroidism. And then we also have increased enterohepatic circulation, as I explained in the last slide. So if you have conditions like duodenal, jejunal, or even ileal atresia, you are going to find that more unconjugated bilirubin is going to go back into circulation. And we see the same problem with breastfeeding jaundice and breast milk jaundice. And I'll just quickly, briefly mention conjugated hyperbilirubinemia, which can be caused by conditions such as biliary atresia, galactosemia, infections, and choledochal cysts. Okay, so what are the signs of hyperbilirubinemia? So we can actually tell the severity, or at least get an idea of the severity based on Kramer's criteria. And this is based on the principle that severe jaundice progresses in a cephalocaudal direction, which means that the more distal the jaundice is perceived from the head, the more severe it is. So you pick this up by blanching the skin in adequate ambient light. So when you do that, you are going to sort of displace the blood, and then now you can see the real coloration of the skin. Okay, so you can do that from many sides, either the face, the chest, the abdomen, the limbs, and then that can give you a fair idea of the severity. However, this should not be used as the only method of determining the severity of the jaundice, and you really need to do the investigation to tell the total serum bilirubin and use that in your treatment to guide your treatment. Okay, so for the signs of hyperbilirubinemia, there are also signs based on the underlying causes. So other causes, depending on the cause, you might find things like pallor, you can have scalp swelling, bruising, hepatosplenomegaly, and signs of dehydration. Okay. So how do we know that this child is going to develop severe hyperbilirubinemia? So we've identified some risk factors that we really need to look out for if you want to tell that, oh, this child needs more attention, because it's possible that this child could develop severe hyperbilirubinemia. So some of these factors are that prematurity, we all know that. So the younger they are, or the lower the gestational age, the higher the risk. And then we also know that jaundice in the first 24 hours is a huge red flag that we need to address immediately. If you have a parent or sibling that was treated for neonatal jaundice, you have a family history of any hemolytic disorder, then you need to take a closer look. And then, as we mentioned, bruising, cephalohematoma, subgaleal hemorrhage, and others. If you see a baby with that, you need to start looking out for jaundice and maybe watch out that maybe that baby may subsequently develop severe hyperbilirubinemia. If you see a baby of a diabetic mother, Down syndrome, babies with Down syndrome, and then when you have rapidly rising total serum bilirubin levels, so that if you find that the levels are rising more than 5 micromole per liter per hour, especially in the first 24 hours, then you need to be on high alert and then now institute intensive therapy to stop the progression. Okay. So now that we know some of the risk factors for severe hyperbilirubinemia, that does not mean that all those with severe hyperbilirubinemia are going to have neurotoxicity. There are actually some risk factors that can tell you that some of these babies are also at risk of neurotoxicity. So some of these are, again, prematurity is one of the things. And then if they have hemolytic disorders, you know that they are likely to have very high bilirubin levels, and then sepsis, and also if they have clinical instability in the last 24 hours, and then also hypoalbuminemia. As I said from the pathophysiology slide, I described the role of albumin and the relationship of albumin with bilirubin, and we need to take note of that because it's very important. Okay. So I'll go straight to the bilirubin-induced neurologic disorders. As I said, it's a broad term that represents a spectrum of neurologic abnormalities. So the occurrence of bind is related to two main factors. As I said, the levels of free or unbound bilirubin and the integrity of the blood-brain barrier. So that if you have high levels of free or unbound bilirubin, you know that you are likely to have brain injury. And then also, even if the levels of free bilirubin are not that high, or the total bilirubin are not that high, and then the integrity of the blood-brain barrier is compromised one way or the other, let's say from meningitis, asphyxia, or severe infections, for instance, even though that level is not so high, because the integrity of the blood-brain barrier has been compromised, those babies are also at high risk of neurologic injury. Okay, so what happens is that when bilirubin crosses, it causes brain cells to die, either by apoptosis or necrosis. And the thing is that there are specific areas in the brain that bilirubin sort of has a predilection for. So mostly is the basal ganglia and the brainstem nuclei for oculomotor and then auditory function. And that is why we have the manifestations that we see. So for instance, the basal ganglia controls movement. So when that is affected, you are going to have movement disorders, specifically chorioathetosis. And then the oculomotor nuclei, when that is affected, they have upward gaze palsy. And then when the auditory function is affected, they have sensorineural hearing loss. Okay, so how can we recognize acute bilirubin encephalopathy? Now, there are three main phases: phase 1, phase 2, phase 3, or early, intermediate, and advanced. So this can help us to look out for these signs when we see a child with jaundice, and then now be able to tell which phase they are in. So in the first phase, they are sleepy but arousable. They may have poor feeding, they have mild to moderate hypotonia, high-pitched cry. And if you're able to treat it either with phototherapy or exchange, as the case may be, you may be able to reverse it at this point. And then in phase 2, which you see from 5 to 7 days of life, you may have fever, lethargy with poor sac, irritability, and or they may be irritable and jittery with a strong sac. And then they may have hypotonia and increased extensor muscle tone, which will be manifested as opisthotonus or ichiocolis, which at this point may manifest with some form of stimulation. Maybe if you stimulate the child, then you start to see retrocolis and opisthotonus. But in phase 3, in the advanced phase, for the intermediate phase, it may still be reversible, although if you delay any further, you might have permanent brain injury. But in the advanced phase, most of the time, they are already on the way to having severe brain injury. So at this point, they have inability to feel, seizures, apnea, and then they may become comatose. And then now you have persistent hypertonicity, which now manifests as retrocolis and opisthotonus, which I'll show you. And they may have bicycling movements of the hands and feet and twitching. They may have inconsolable cry, or the cry may be absent or weak. And then they can die from respiratory failure or intractable seizures. Okay, so we have this blind score so that you can now, that can help you to assess the severity of the acute bilirubin encephalopathy. So with this score, you can categorize them as either as a mild, moderate, or advanced. Get it? So the parameters used are the mental status, the muscle tone, and the cry pattern. So based on these scores, now you can tell that maybe they are having mild or subtle signs of AB, or they are having moderate, or they are in phase 2, or they are in the advanced phase. And that can help you to predict what may happen, or how quickly you need to treat this patient in order to avoid further injury and then worse outcomes. Okay, so the buying score is available for us to use. So this is a diagram, this is a picture of a baby that seems to be progressing through the phases of acute bilirubin encephalopathy. So already in the first picture in A, you can see some upward gaze palsy with the lid retraction. Already, you can already see that the baby is deeply jaundiced. And then in the second picture, you can see the extension of the neck, which we call retrocolis. Okay, so it's already starting. You can already see retrocolis. And then in the third picture, that is the C, you start to see the bicycling movements of the hands. Okay, and in the last picture, you can see the fixed retrocolis posture, and some degree of opisthotonus. That's when they arc the back, the neck and the back. So that is the opistotonic posture. All right. Okay. So we've talked about acute. Now we move on to chronic bilirubin encephalopathy or kernicterus. As I said, this is more from permanent post-icteric brain injury. And based on the parts of the brain that are affected, that's why you see the symptoms. And I showed you the basal ganglia and then the brainstem. Now, the risk of developing CB actually depends on the severity of the hyperbilirubinemia, and then the duration which the brain has been exposed to that level of hyperbilirubinemia. So if you're able to deal with that, then maybe you can help reduce the severity. But the longer it goes on for, the more likely that this child is going to have severe forms of CBE. So it presents in two forms. In the first year, the patients may present with hypotonia, exaggerated deep tendon reflexes, obligatory tonic neck reflex, and delayed motor milestones. But beyond the first year, that's when you start to see the more classic manifestations of kernicterus that we know of. That's the chorioattitoid cerebral palsy, upward gaze abnormality, and sensorineural hearing loss. And then also, sometimes rarely, they may also have dental enamel hypoplasia. Now, in general, their cognitive function is relatively spared, which means that they they don't necessarily have intellectual disability. Some may have, but some too may have retained significant cognitive function, which is good. So this is a specimen showing the brain that has been exposed to high levels of bilirubin. And as you can see, number two, you can see that the basal ganglia has been pigmented, in addition to other areas in the midbrain. Okay. And this is a short video showing a child with chorioattitoid movements. So you can see they are involuntary and then unpredictable movements. And it's actually difficult for the child to control because he's not voluntarily making those movements. So it's quite a challenging condition to have. All right. And this picture shows a child with dental enamel hypoplasia, where you can see the yellowish or greenish discoloration of the dentition. And then they also look hypoplastic. So this is how they would look. So, but this is not very common. Now, it is important that we take note that not all cases of acute bilirubin encephalopathy is automatically going to progress to kernicterus. As I said, sometimes even in the early phase, you can reverse it, okay? And at the same time, not all children who present to you with chronic bilirubin encephalopathy or kernicterus may have, let's say, a previous history of bilirubin encephalopathy. They may have had a previous history of jaundice, but not necessarily acute bilirubin encephalopathy. Understand? So it's important that you take note of that when you are taking your history. Now, even within the category of chronic bilirubin encephalopathy, what happens is that not every child is affected to the same degree. So some have mild manifestations and some have severe. Now, so because of that, they came up with the term kernicterus spectrum disorders, so that some may have maybe a single or isolated disorder, whilst at the extreme end, they may have all the full manifestations of severe um, kernicterus. You understand? So some may present with, let's say, disorders in the visual cortical pathway. So they may have vision problems. And then some may have maybe isolated sensorineural hearing loss. Some may have gait abnormalities. They may have speech and language disabilities or cognitive delays. Okay. Yes. So there's actually a spectrum. So within this category. There are varying degrees of manifestations, and we need to take note of that. Okay, for the investigations, I will not bore you with all of this, but then the main goal is that you really want to know what is the level of bilirubin in the blood, what is the underlying cause, and then also identify any risk factors that you can to help you know whether this child is likely to develop neurotoxicity or not. So that's really what you are trying to do with all these investigations. And chief among them is the total serum bilirubin, which you need to know. And then you can do all the other tests to help you achieve those goals that I mentioned. Okay. But specifically for those with bilirubin encephalopathy, you really want to for instance, as I said, they may have sensorineural hearing loss. So because of that, you want to test their hearing, ideally before they may even go home. So the test that can be done for them is a brainstem auditory evoked response. Okay. And then in the acute and chronic phase, MRI may have some characteristic manifestations that can help you tell that these patients have bilirubin encephalopathy. So how do we manage this situation? Ideally, the best strategy is to prevent severe hyperbilirubinemia in the first place. So how are we going to do that? We need timely diagnosis and treatment of jaundice, especially within the first week and particularly within the first 3 days of life to prevent severe manifestation. So what are some of the strategies we can use? That is the prenatal screening of high-risk families, which we do somewhat, we partially do, the ABO resource incompatibilities, and then the G6PD. But oftentimes we don't know the blood group of the father. It's just the mother that we have in the book. And therefore we cannot tell maybe what blood group the baby may have. And so we need to test for that when the baby is coming and now compare with the mothers. And then also pre-discharge screening of neonates, whether SVD or CS, we need to at least take a quick look at the babies before we allow them go home. Because some of them actually develop the jaundice on the ward before they actually go home. And now they themselves, if they are aware of the condition, are able to pick it up and come back to the hospital. Otherwise, who knows what would happen to some of them. And also post-discharge, as suggested by the World Health Organization, they suggest that on day 3, babies are supposed to be followed up, and then also on day 7 of life. And this, I think, would really help to identify jaundice in newborns early enough. So what are some of the other strategies include the advocacy and community engagement, especially at the national and local levels, which we've been doing for years now. Okay, so we can continue this and also intensify these efforts and also advocate for equipment for screening and early identification and treatment. And usually multiple organizations are able to donate phototherapy to the hospitals that can help also to treat this condition. The radio and TV programs we can go to help dispel some of the myths. And the picture insert you see is what we've been doing at our hospital to try and raise awareness in the community. Now, I put this in just to highlight one worrying trend that has been happening of late. And unfortunately, it seems to be coming from the healthcare workers. I mean, I've had a few instances where the parents have informed the healthcare worker that they think their child has jaundice, let's say on day 1, day 2, or day 3. But then unfortunately, the feedback they get from the health worker is that they should just continue breastfeeding. So I just wanted to bring this up to let us know that breastfeeding is actually very important. Yes, it's very important in helping to treat, but breastfeeding alone cannot treat severe jaundice. So if you are not careful, a child comes to you on day 2, tells a mother comes to you on day 2, tells you that my baby has jaundice, and you, the health worker, now say, oh, go home and go and breastfeed because you think at this moment it is not that high, and you don't give any other instruction, come back later, or do this lab, or do this, or look out for this and come back. And then now they come back on day 7 with severe jaundice, and then they are now on the verge of bilirubin encephalopathy. And I've had at least 2 or 3 instances in my own facility where the mothers recognize it, but unfortunately, someone had told them that breastfeeding alone is supposed to clear it. And I think that it's not the best, especially coming from healthcare workers. So I got this just from what our keynote speaker said. Eyes, we the health workers have to be the eyes that spot it early, and then the hands that treat it right. So I think we are actually doing a really good job. And then I think, well, in my facility, jaundice, most of them come in mild, and then we are able to deal with it early. And it's rare that we see a child with severe jaundice. As for the management, I think my colleague will be dealing with it later. These are some of the devices, but specifically with the chronic bilirubin encephalopathy, with a hearing loss, for instance, if the children have that, they usually would need cochlear implants. And for the motor dysfunction, as we saw, it's actually quite difficult to treat. And there are only a few treatments available, such as oral medications such as benzodiazepine, and then also baclofen, particularly for those who have spasticity. Okay. I also came across some novel therapies that are under investigation. Now, although they just mentioned them and they are really just under investigation, there's not too much that can be said about them. So they are still undergoing um, investigation. So this is just to let us know that um, there are still therapies out there for bind, that people are still looking for ways to reduce bind and also to treat it. And also from the therapy, since I've been talking about complication, I want to talk about complications from the treatment we also start. For the phototherapy, they may have an erythematous macular rash. They may have hyperthermia or hypothermia, depending on the device you are using, and also fluid losses from the loose stools and the insensible water loss. And for some of the children with conjugated hyperbilirubinemia, they may develop what we call the bronze baby syndrome. That's because of the type of jaundice, the type of bilirubin as the conjugated form that is in their blood, and that gives it that grayish brown discoloration of the skin and urine. And there's also the possibility of retinal injury. Although when I looked at the studies, it's not really conclusive, just that the possibility is just there. So we just want to prevent it. That's why we put on the eye protection for those we put under the phototherapy unit. And then for extreme transfusion, it's a little invasive, so they can have hemodynamic instability, thrombotic complications, such as portal vein thrombosis, air embolus, and there's also a risk of necrotizing enterocolitis. Okay, so in summary, despite the relatively simple and accessible treatment of neonatal jaundice, we still see a few incidences of bind, although from my end, it is not too common. Just that when we find it, it's usually because there's some communication problem or some of the community practices that may have been instituted instead of reporting to the facility, and that led to the late presentation. So as we've also identified, bind has a wide spectrum of symptoms, from mild neurologic disorder to the classic connectors that we know. And as I said earlier, patients not always have all the symptoms of bind, especially in those in the chronic bilirubin encephalopathy group. So it's always a range. And then early detection of high-risk neonates for severe jaundice is the best modality for preventing bilirubin-induced neurologic disorders. So prevention is the best strategy we have, especially in this part of the world. So we need to really take note of that. So in conclusion, vigilance on the part of parents and also healthcare workers can save many of the futures of our children. And then zero tolerance for connectors through standardized screening and rapid response can go a long way to help prevent connectors. Thank you very much.
Wow. Wow. Dr. Pepper, thank you very much for the insightful presentation and adding up to what we already know. I'm sure each and every one of us have taken notes, and I'm sure people have questions to ask. So, in 2 minutes, I'd like to take questions for Dr. Pepper, then we continue with the second presentation. So, if you have any question, kindly raise up your hand. You will be called to answer, to ask your questions, or you can write in the chat box. Any question? I think maybe we want to ask after everything, and so we'll continue with the second presentation. But then before we go, the evaluation form for the meeting is posted in the chat. And so kindly fill it and give us your feedback on the webinar. So without much ado, let me introduce the second speaker to us. He's an experienced pediatrician and public health professional with extensive expertise in child health delivery, clinical leadership, medical education, and health system strengthening. He currently serves as the pediatrician specialist at the Pediatric and Child Health Department of Volta Teaching Hospital, who is currently the HOD for the department. He is also a part-time lecturer at the University of Health and Allied Sciences. In addition, he leads pediatric specialist mentorship team under the USAID-funded Integrated Health Partnership implemented by Project Hope. His professional work focuses on pediatric care, quality improvement, clinical mentorship, humanitarian health service, and capacity building in low-resource settings. He actively involved in professional and advocacy activities through the Pediatric Society of Ghana and the Ghana Medical Association, where he contributes to improving child health outcomes and strengthening healthcare delivery system across Ghana. This is no other person but our own friend, brother, doctor, and everybody knows him as Trax, Dr. Selom Trakasu. Boss, if you can hear me, your audience are here and are waiting for you. I can see your slide as well.
Thank you very much. And thank you for this elaborate introduction. I'm humbled. Anyway, I hope my slides can be seen.
Yes, please.
Should I make it a
Yeah, put it in
slideshow?
yes, please.
Okay. Awesome. So it's in a slideshow.
Yes, please.
All right. So I want to appreciate again the organizers of today's program for involving me in today's webinar. And also I want to appreciate my colleague, Dr. Pepra, for doing a no man's job in his presentation. In fact, as he spoke, I realized he touched on very important issues that we'll be looking at or addressing in this next presentation. So my task now is to take us through a case management discussion. As you can see, we'll look at missed opportunities, evidence-based informed protocols, and expectations for us all healthcare workers. So the objectives, mainly we'll use the case to identify clinical and system contributors to severe neonatal jaundice. We'll review immediate priorities in terms of assessment, bilirubin measurement, phototherapy, exchange transfusion readiness, and neuroprotection. We'll be discussing missed opportunities across postnatal care, referral systems, emergency care, and inpatient monitoring. And then we'll come to some consensus as healthcare workers, what should be our expectations for us all, even as we launch this campaign. So this will be my presentation outline, and then some questions we'll look at after the presentation. So this is a case snapshot, a case that was managed just a few weeks back. Key clinical facts from the case. So this is a baby, a term male neonate, who was brought to the emergency room at day 10 of life by the mother, who had apparently noticed jaundice 7 days prior to presentation. So at this time, the baby was 7 days old and had involved the face, the trunk, and the limbs. She had presented to the health center at day 7 of life and was allegedly told by the health staff that it's nothing to continue breastfeeding. And so when I heard my colleague talk about how he's had to deal with cases of this nature, I was like, wow, it means we have a lot of work to do to bring on board all our colleagues to understanding the relevance of early detection. So you can imagine, mother did the right thing by bringing the baby to the hospital. And the health staff said it's nothing, just continue feeding. So by the time they brought to the emergency room on day 10 of life, baby appeared severely jaundiced. There was history of persistent vomiting, poor feeding, appeared severely dehydrated, and had neurological signs of lethargy, shrill cry, and dystotonous posture. So we'll see that from the overview, we're approaching advanced phase of severe jaundice or bind, as we are saying. So the initial total serum bilirubin done was 791.7 micromole per liter, with the indirect component 624.3 micromole per liter. GCSPD done showed full defect, and so the diagnosis was severe neonatal jaundice secondary to GCSPD deficiency complicated with bind. Subsequent serum bilirubin levels showed that it had dropped, but not that significant, to 311 and 250. So when you look at the clinical timeline of the child, so once baby was brought in, intensive phototherapy was started, IV fluids, labs were done, IV antibiotics were given, and then plans were to do an exchange transfusion. However, between admission day 1 to 4, this exchange transfusion did not come off. Why? Because the umbilical stem area had healed, and so access to the umbilical vein appeared impossible. And the child's condition had even deteriorated further. The dystotonous posture, was not feeding well. And so by day 6 of life to 7, there was hypothermia, bradypnea, multiple episodes of apnea, and reduced consciousness. That same day, child had to be resuscitated, but was pronounced dead. This is a case we want to look at, and I believe some of us may have even had to experience this situation. We know from the statistics that have been presented, newborn jaundice still remains probably top 3 causes of neonatal morbidity. But of course, when it comes to mortality, it's not so high. But if it comes to the family, if you lose your child, that mortality is 100%. So let us see how we can address this kind of situation differently as healthcare workers. why is this, why this case was a high risk to bilirubin neurotoxicity and death? What are the factors we can consider just watching the clinical scenario and the timelines? If we take, for instance, the time of presentation, the history suggests that the mother noticed jaundice on day 7 of life. Question is, how accurate even is that? You know, even in our culture, most of our mothers or families hide our babies in their rooms away from obvious bright light. And so they might not really see how jaundiced their babies are because of how dark the room is. And of course, most times babies close their eyes, so they are not even going to get the opportunity to see the eyes of these babies. So mother coming to the hospital, even on day 7 of life, claiming that's when she noticed jaundice, may not even be when exactly the jaundice started, considering even the investigations that were done further, which showed that it was G6PD full defect. We'll know that this jaundice probably started earlier, maybe even day 1 of life. So the time of presentation was obvious, late presentation. The extent of the jaundice on the body of the baby, you will see that at day 7 of life, mother had seen that the jaundice had gone across the whole body, the trunk and the extremities. And this apparently did not inform the healthcare worker how serious this jaundice had become, and just allegedly advised mother to go home and continue feeding. So again, this was another missed opportunity. When you go down, we see that the condition involved, which is G6PD deficiency, is one of the major causes of severe jaundice in babies. And if it's not identified early, can lead to poor outcomes. You see, from the reduced handling, poor intake, poor feeding was one of the major signs that was shared by the mother. And that tells you something. We saw from the previous presentation, when there is decreased motility, that leads to increased enterohepatic circulation and reabsorption of bilirubin into the blood system, which then leads to, it gets into the blood-brain barrier and can cause worse damage to the brain. The serum levels, again, you see, we realized was 791.7 micromole. When I was a house officer, they used to tell us that, a crude way of just deciding when to intervene, that 240 micromole per liter is photo level, 340 micromole per liter is exchange level. So you can imagine coming with a level as high as 791, far above exchange level. And that shows, that tells you how bad the situation was. So this again was a reason for a high risk for bilirubin neurotoxicity leading to death. And so we are not surprised that the symptoms that baby presented with at the emergency room were symptoms and signs suggestive of acute bilirubin encephalopathy, or what we said falls under the bilirubin-induced neurological disorders, lethargy, abnormal cry, and abnormal reflexes. And that led to baby's death. So we want to look at missed opportunities. As an individual, as a team, as a system, health system in place, what are the issues? One of the missed opportunities is community or stroke postnatal review. From what we've discussed so far, there was no review dates allocated to the mother until she reported on day 7 of life. And what do we see on the ground? Most times, we are ask, or we tell our mothers after they deliver their babies, spontaneous vaginal delivery, most times, once they go home, we say, oh, come back after 7 days. What happens between day 1 to day 7, nobody knows. And so this was a missed opportunity. How well was the postnatal review communicated to the mother and conducted? Another missed opportunity was the risk recognition. The healthcare worker was unable to recognize how seriously this baby was sick when the symptoms and the signs were obvious. And so that led to the baby's deterioration and ultimate death. Another missed opportunity was emergency escalation. So obviously, once you are not able to recognize the risk that this baby was facing, there was no escalation. They were just asked to go back home. So if there was that understanding, immediately what would have been considered was admission and then initiation of certain interventions like phototherapy or exchange transfusion. Or if it's not even possible at that health center, then a quick referral to the hospital that can offer it, whether the regional hospital, the district hospital, or even the teaching hospital. Another missed opportunity I think we should be also looking at is how available are protocols when it comes to managing newborn jaundice. For many healthcare workers, I think from the keynote speaker, we assume because we've gone to school, we've gone through training, is adequate. But no, there's supposed to be continuous in-service training and orientation on some of our protocols. So was there a clear protocol, a clear written algorithm to follow so that whether an old nurse or doctor in terms of experience or a new young doctor or nurse who has been posted to a health center, is there a protocol laid out, clearly positioned that they could have referred to, even if you don't remember exactly what to do, and the mother comes with the baby, oh, my baby is jaundice. If you don't even remember what to do, you could just refer to the protocol and say, oh, okay, what does the protocol say? Mother comes with jaundice. That maybe could have changed the situation. So we have to begin to advocate for protocols to be made available at all health centers when it comes to management of all kinds of conditions. It will serve as a good reminder to all of us. So that again was a missed opportunity. Counseling of the family. How well was this family counseled even before, during antenatal clinic and postnatal clinic? Was family counseled appropriately on how to examine the baby at home, whether to make sure they do it under bright light or under the sunlight, how to identify danger symptoms and signs? Because the poor feeding, the opisthotonous posture were all red flags, but the stages of deterioration will start with milder symptoms. Was the family educated on some of these symptoms so that once they pick them up, they would have quickly come to the hospital? So again, that was a missed opportunity. Lastly, how appropriate was the medical intervention? So we see there was a delay in presentation at the emergency room. And once there was a delay, bind had set in. The neurological function of the baby was beginning to deteriorate. But the healthcare workers who had received at the emergency room, why wasn't exchange transfusion considered? Reasons were given, but was it enough? Could something else have been done to still carry out this exchange transfusion? And would they have even changed the prognosis of this baby, considering the fact that it was becoming advanced? But the question here is, was the appropriate medical intervention applied? So these were some of the few missed opportunities I think we should consider. So as healthcare workers, doctors, nurses, in charge of units, I would employ that we apply this root cause discussion framework. It's a simple framework that we can apply to our units to try to assess the systems that we have in place. And it cuts across people, which is with the healthcare workers, the process, equipment, blood or investigation or laboratory services, patient factors, and communication. As people, healthcare workers, what's the level of knowledge when it comes to newborn jaundice, danger signs, protocol, what to do? We should be able to assess our healthcare staff to see at what level they are. And if we realize that they are not, the level of knowledge and understanding is not there, then we should be able to carry out training programs to bring them up. And that's why I'm happy we're having this webinar. It's one of the ways to get most of our colleagues to come to the same level of understanding. Process, as I touched on, what algorithms, what protocols, what work plan has been set in motion so that whoever you are, no matter how experienced you are or newly posted, you can always refer to that algorithm. You can always refer to that SOP to guide your work. Equipment. What is the equipment situation in your facility? Do you have the phototherapy machines? Do you have oxygen? Do you have CPAP? Do you have the Firefly? Do you have the checklist for carrying out an exchange transfusion? These are things we should be talking about. And if as a facility you don't have some of these things, you should put pressure on your procurement to help you get them. Or as part of your advocacy, ask for some of these equipments to be provided for you. Or else, when the cases come, you will not be able to do much. Our labs must also be upgraded. How many of our labs can carry out blood, provide blood for us? Very few. Maybe the teaching hospitals, the regional hospitals are doing it. But what about district hospitals? They all need it because that's where the parents come to. The patient factors in terms of the counseling, the education we give them, how appropriate is the education? Do we have manuals that we have vetted so that we can use it as a means of educating our mothers and guardians on newborn jaundice, how to screen them at home, as I've mentioned earlier. So this is a framework we can apply, and where we are deficient, to quickly make the necessary changes so that you can reduce the risk of severe jaundice, and that will lead to bind and fatal deterioration. So part 3 of my presentation is focusing now on the literature-informed protocols, what current guidelines and reviews we should be considering. First on the list here is the newborn assessment protocol stroke frequency. And my colleague did some justice to it. He mentioned how it's important to screen baby at certain times. He mentioned 2 to 3 days and at 7. I want to just quickly show you this is a protocol by the WHO recommendations on maternal and newborn care, something that we can print and paste on our walls. And this tells us, it says, it's an assessment from routine assessment timing for healthy newborns. So as we commonly see, mostly at birth, and then sometimes the next time is at day 7 of life. So within 24 hours, day 3 to day 5 is all lost. And yet the window the critical window for which jaundice, severe jaundice can lead to bind is the first 10 days of life. So if screening or newborn cell is not well done within this period, then you are risking this baby of developing bind. So we have to adjust and reorient ourselves how we are going to be conducting newborn assessments for our babies at the district hospitals, at the polyclinics, at the teaching hospitals. It cannot be just at birth and then the next time at day 7 of life. We have to start considering how they can return in 24 hours, how they can return at day 3 and day 5, and then day 7. And I dare say, even 2 weeks, 3 weeks, there have been cases of babies developing bind at 2 weeks and 3 weeks of life. So consistent screening is very key. So this is an important protocol we can look at. The next guideline, which we should emphasize, is measure, don't guess. Measure, don't guess. Some of us are suffering from color blindness. So the mother says, oh, I've seen my baby looks jaundice. Then you look at it, it doesn't look jaundice. So now we are following your judgment. But for all we know, you, the healthcare worker, you are dealing with some color blindness. So I tell my house officers, if a mother comes to the OPD and complains that my baby looks jaundice, even if you can't see it, you think she's overreacting, don't rubbish it. Go ahead and request the sample, the test, the total serum bilirubin. Let it come and then show it to her, plot it so that she'll see that indeed is below the threshold for it to be escalated for a phototherapy or exchange transfusion. So let's not be guessing. So the third point is use the appropriate measurements or scoring systems. So when you do the total serum bilirubin, there are documents or scoring systems that we can use. Let me just show you one. Yes, this one here. This is more objective and helps for you to measure appropriately and plot appropriately the level of total serum bilirubin that is in the baby and whether or not it's below or above the threshold for phototherapy or exchange transfusion. So these are very objective manuals that we should have readily available in our consulting rooms, in our nursing stations, on our wards and emergency rooms. All right. So once you've done the plotting and you've identified how serious it is, escalation is key. Escalation simply means do something about it immediately. So if it's just above the threshold for phototherapy, you can go ahead and start your intensive phototherapy and hydration, very important. If it's above exchange, immediately refer to the appropriate facility that can carry out exchange transfusion. If there are signs of acute bilirubin encephalopathy, immediately escalate for exchange transfusion. So these are very important guidelines that we should be considering as part of monitoring and managing babies with newborn jaundice. So this is just a proposed algorithm that I'm sharing with you now. So right from baby being noticed to be jaundice, triaging is very key, considering the age. Jaundice baby seen, you triage the age, what's the feeding pattern, looking out for danger signs, which has been already discussed in the previous presentation. Once you've done that, immediately take your samples, check for total serum bilirubin, or if you have the device, transcutaneous bilirubinometer, to help you tell exactly the level of jaundice in the baby. And you plot and determine, is it above the threshold for phototherapy or above the threshold for exchange transfusion or below those thresholds. If, depending on whatever the plot says, you go ahead with the appropriate intervention, which might be no treatment, baby is fine, or phototherapy, or escalate and do exchange. So these are very important. This is a very important algorithm I think we can follow. And if we do this judiciously, we will not miss any case. All right. This has already been discussed, which is the bind score, which helps us to tell the severity of the newborn jaundice. So I will not go through it again. So the last part of my discussion has to do with management. What should happen when severe jaundice is suspected or confirmed? So as we always say at the medical school, in the first 10 to 30 minutes, always do your airway, breathing, circulation, check for exposure and temperature. You measure the bilirubin now, and if it's above the threshold, you carry out your intensive photo. Hydration is very, very key. Monitoring for random blood sugar, the temperature are all key. If there's a risk of sepsis, initiating IV antibiotics is important. And then if you have to escalate and involve a senior person like a pediatrician in your facility, or even if you have to call from a different facility, it all helps to save the baby. The history and examination is key. So you have to go through the history and ask all the necessary questions that will help you come to a proper diagnosis, what exactly could be causing the jaundice in this baby. So I wouldn't bore us with this since that has been covered. So intensive photo is very key. When we are doing intensive photo, always ensure we use the correct light source, ensure blue spectrum light and appropriate distance per device. Usually we say the length of an A4 size paper sheet is an adequate distance to ensure that baby gets adequate spectrum of the light to reduce the jaundice. Maximize exposed skin. So remove all the clothing except for what will cover the eyes and the genitalia so that everywhere gets the photo light. In stable babies, continue feeding with express breast milk unless contraindicated. And you can always support with IV fluids because phototherapy can also lead to dehydration. And during the period, it's important to monitor temperature, hydration, urine, and stool outputs. And very important, whilst on admission, always recheck your total serum bilirubin early after initiation and at defined intervals. Usually can be every other day or every day, especially if it's high. And then once it's getting lower, every other day. So phototherapy is a treatment, not observation. Ensure to document start time, device type, skin exposure, eye protection, and hydration. All right. So we've touched on this, how important it is to escalate whenever it's above the threshold for exchange transfusion. So some of the red flags we have talked about in our previous presentation, the age of presentation. Mostly we say jaundice noticed in the first 24 hours of life is pathological and must be taken very seriously. But oftentimes it may be missed. And so if it comes even day 2 or day 3, don't snub the parents, still insist and run the tests and be sure it's within the threshold. Or look out for feeding problems poor feeding, vomiting, weight loss, reduced urine or stool are all red flags that child is deteriorating. And the neurological signs are, you can see, of all the colors, this is red, which means it's getting advanced. Do something immediately. All right. So exchange transfusion checklist. How ready is or our facilities? First of all, the human resource have to be trained to carry out exchange transfusion. So if you are at a facility where at least you have a blood bank, then that is an important milestone. If you ask, you can just get the skill. Like you can come through the teaching hospital and we can help you, train you so that cases of that nature, when they come, we can help you carry it out right at the district where you are. So the human resource is very key. Another important thing when it comes is the equipment. And usually all you need is feeding tube and three-way tap. Very simple gadgets that can help you carry out an exchange transfusion. For this particular presentation, we are not going to go through the process of exchange transfusion, but we should have an exchange transfusion readiness checklist. And I'm willing to share that checklist with us after the presentation, something we can look at and make sure we have it available, the items available, so that anytime a baby is brought jaundice, you are ready to offer that help. So our inpatient monitoring is also very, very important. Checking the total serum bilirubin at different intervals, which should also correlate with the clinical state of the baby. So even if the baby is beginning to show signs of deterioration neurologically, and yet your total serum bilirubin levels don't appear to be that high, you should still show concern. It can be an indication to still carry out exchange transfusion because every baby is different. Some babies just a certain threshold and they begin to show signs of bind. And so whilst on admission, monitoring should not just be the serum bilirubin, but also the clinical state of the baby should be monitored. So finally, what are the expectations for all of us? As midwives, community health nurses, postnatal staff, do not reassure mothers who come with their babies with progressive jaundice without doing an objective assessment, like testing the baby. And we should also be teaching our mothers and our guardians the danger signs that they should look out for in their babies whilst at home. As staff at the emergency units, doctors, nurses, we should be able to recognize severe jaundice and initiate the pathway for intensive photo. And if it's not working, have our readiness to carry out exchange transfusion at all times. Our specialists and team leads must also be available to help teach the younger ones how to do these procedures. And we should advocate for up to upgraded laboratory units in our facilities so that they can offer us real-time reports on total serum bilirubin and also provide blood when needed for exchange transfusion. And of course, our management who handle or take care of us, we must advocate so that they'll begin to see it as a priority in helping us manage cases of newborn jaundice. So in a nutshell, this campaign is to ensure that we see jaundice early, measure bilirubin early, treat it early, escalate it early. Severe jaundice is a time-critical neonatal emergency. Delay in bilirubin measurement escalation or extreme transfusion may result in irreversible bilirubin-induced neurological dysfunction. Thank you very much. So this is the end of my presentation.
Wow. Thank you so much, Dr. Trakasu, for that nice presentation. I think there is a lot of applause for you here. You can see clap everywhere. Thank you so much. So I think so far so good. We have a very nice time with the two presentations. So I would open the floor. If anyone have any question, kindly raise up your hand. We call you, then you go ahead to ask. If probably you are in a noisy environment and you wouldn't like to talk, you can type the question in the chat box. Then I'll read it out. So thank you, Dr. Pepra and Dr. Chakasu, for that wonderful presentation. The floor is now open for questions. So I think there is a first question in the chat box from Memuna Abbas Tanko. She is asking, please, was there a feedback to the facility that the mother first sent the baby in the case presentation? I think this is to Dr. Chakasu.
Yes, a feedback was sent. And in fact, our goal is to be able to reach out now more to our community health nurses and public health nurses in the who man our CHIPS compounds and polyclinics, because we've seen that the information, the sort of advice that will go home, just continue breastfeeding, is mostly coming from those centers. So if there are some here, I'm very happy so that they can share the information to their colleagues as well.
All right, thank you so much. I think for the advocacy, we still continue, and the community engagement we are still doing. Whole Teaching Hospital was in Kpetoe last week, Saturday, and to share with the caregivers, mothers, the community members, as well as the healthcare workers. Yeah. So we still continue. If there's any other question, please raise up your hand and ask. Before then, there are links to the evaluation form in the chat box. Kindly fill it out. We need your feedback to plan others. So we are waiting on your feedback as well as the questions. Hello. Can I be heard, please?
Yes, we can hear you loud and clear, Jonathan.
That's fine. That's okay. It's like everybody has understood.
So I think we'll also encourage those who like some of the protocols we've discussed. They can leave their emails so that we can share it with them, get it printed, laminated, hanged on the walls, put at the workstations, so that we can all have the same mind and follow through with how we manage these cases.
Yeah, I think
That's
that's
what I advocate for.
Yeah. Any question, any addition from someone? Dr. Saba, I think you have a question for us. I think, yes. Dr. Daniel, I know you also have a question or a suggestion or a submission for us, so the floor is open. So, Dr. Chokasu, the emails are in the chat box.
Okay.
Hello, good evening, Jonathan,
Good evening,
and
Dr.
good
Daniel.
evening to the two presenters. Very excellent presentations. Unfortunately, whilst we are driving and talking advocacy, what this is resulting in is that we are having a lot of mothers paying more attention to the eyes of their babies, and our photo units may be overwhelmed. So it is important that we pay particular attention to what Dr. Takasu mentioned, particularly having a good threshold. When do we initiate phototherapy? Having good laboratory supports and then the rest. So it's important we take this point very seriously. And once again, thank you to Dr. Takasu and then Dr. Pupra. Over.
All right, thank you, Dr. Daniel, for the add-up. If you are now joining us, we are talking about neonatal jaundice, having a webinar on it. We are looking at the overview of neonatal jaundice, its associated complications. Yeah, so we had a whole lot of chats with Dr. Pepra, a pediatrician from the Margaret Marquardt Hospital in Kwando, and a pediatrician in Ho Teaching Hospital, Dr. Trakasu. Yeah, we had a lot. If you need the protocols for any of the information he provided, kindly leave your email in the chat. Then he'll forward everything to you. There is also a link to the feedback in the chat box. Kindly fill it out. If you have any question, kindly raise up your hand. Any suggestion, you are welcome. Dr. Nelly, I also think you have an add-up for us, a suggestion, a question. So kindly speak out to us. So Dr. Chokaso, a lot of the emails are coming.
Yes,
I
I
don't know
can
if you
see.
are taking notice of them.
Yes, so we'll copy all the emails and then share it.
Okay. Can we get the nanograms for the various preterm ages as well? So I think Dr. Chokaso again.
Yeah, so Jonathan, if you can hear me, I think that we can work with Dr. Takasu and then Pupra and try and get this into a user-friendly SOP form that we will share on the Pediatric Society of Ghana Volta page. So those who would want it, as we are leaving our numbers, try and get in touch and join the page. So hopefully it should be something we should be able to put together before the end of the Jaundice Awareness Month. Thank you.
Yeah. Thank you, Dr. Daniel. Okay. So I think there is no hand up. Everything is well understood. And so well, since everything is okay, then I will call on our chairperson to give us her remark. Dr. Ekuban, if you can hear me, we are done with our session. The floor is to you now. We want to have your closing remarks. Hello, Dr. Ekuban. Hello, Dr. Ekuban.
I hope maybe she's talking about muted.
Yeah, I think so. I'm checking that. Okay.
So
Since
as Dr. Daniel mentioned, I'm trying my best to capture all the emails in the chat box, but maybe we'll put we can just put a list up on the PSG platform so that as many as can just add up their emails, and then from there we'll also be able to share all the protocols on the platform.
okay. So whilst we wait for our chairperson to give us the closing remarks, I think I could call Dr. Tege if she is also on the call to if she has something for us. Dr. Tege, if you can hear me. Okay. Oh, we are almost done with today's webinar. And we were talking to Dr. Pepra and then Dr. Chakasu on the overview of neonatal jaundice and its associated complications. We've looked at a lot of literatures, all coming from the keynote speaker, the chairperson, and then the presenters. And so the advocacy continues throughout the month. I'm sure the presenters will also make their slides available if we need them. And so those who are not here and would like to also have an insight of what happened today, probably they can also get the link on YouTube at the Pediatric Society of Ghana's YouTube channel. Yes. So on these notes, our chairperson is, I'm sure, off the line, and so we take our closing prayer. Mr. Cross or someone, if you're on the line, kindly pray for us.
Thank you very much. Okay, please, we are praying. Please, can I be here?
Yes, please, go ahead.
Okay, Heavenly Father, we thank you for bringing us together today through technology to learn and grow in fellowship. So as this virtual class comes to a close, calm our minds from the simulation of discussion. Quiet our hearts as we prepare to log off and return to other tasks. Help us take the lessons and perspectives absorbed here today and apply them well. Grant safe travels for all who are leaving their work or study spaces. Bless our times apart and reunite us again with open hearts and minds. Remind us always that though separate, we are still united in spirit. We thank you for this time and pray this in the name of your Son, Jesus Christ. Amen. This one,
Amen.
you put the first one on me. Hey.
Amen.
Amen.
you.
Thank you very
Oh,
much. And thank you everyone for making it.
Honorable moderator, at least I was
Amen.
trying to say something. The keynote speaker is also the Ghana Registered Nurse
That,
Midwife, original chairman.
that's
That's
what I'm
my
coming to
chairman.
say. That's what
Yes,
I'm
thank
coming to
you.
say. Thank you. Thank you. Thank you very much.
Mhm.
That's Bra Courage. And also a board member of the whole teaching hospital. Yeah. All right. Thank you all for making it to the success of today's webinar. We thank you and we'll reach out to you next time. My name is Jonathan Kwame Kwashi, the Pediatric Society of Ghana Volta Branch Organizing Secretary and your moderator for today. Bye-bye.
Bye. And thank you.